I'm going to discuss the management of overactive bladder in the male radiated patient. That's a good question. What does work? We spoke a lot about radiation, and radiation admittedly works well, is integrated into a lot of our algorithms for treating pelvic malignancies, among them also cervical, which I'll speak about a little bit later. And so it's integrated well into our multimodality therapy. This is some data from the ACS looking at the utilization of prostate cancer by age as a primary treatment. And if you look just in my practice, almost half of my patients that I operate on are radiated. If you stratify that by their primary cancer diagnosis, of course the primary group is prostate, followed by colorectal, and then the cervical rounds out my top three. And what we see, or what I see as a reconstructive urologist, is this is the standard salvage prostatectomy that had a bladder neck contracture and has been open a couple times and has all this white appearing tissue and some calcifications forming on the necrotic tissue. So basically looks like a bomb bomb went off. We know about the radiation effects on the lower urinary tract, and this is instilled into us from learning from our basic science years in early urology about the acute and chronic changes, as well as this obliterative endarteritis and the ischemia and fibrosis that can develop over a decade or more. When we look at the bladder toxicity, the dose that you would expect to see with the treatment of some of these pelvic tumors, you can see them listed here in the range of 60 to 80 gray. Our radiation oncology colleagues do describe to some degree the acute and late morbidity seen in the bladder. It's interesting in this RTOG, EORTC categorization that they don't actually have a separate one for urethra, but when we scope that, we can definitely see that there are changes in the urethra, and we'll take a look at the radiation planning in a moment. We're going to be looking at these patients in this grade 2 to 3, so hopefully have not, their bladder's totally not destroyed at this point. They're not having severe hemorrhagic cystitis, but they are having, bladder symptoms and frequency and things that would be in the overactive bladder description, but are really related to radiation. So I often look at these radiation treatment planning, and you look at them and you really can't tell, what's going to happen in terms of somebody who has this is someone who ended up finally with an exent versus someone who had, no complications at all. But if you do just look at them a little more closely, what you do see is that as look at the dosing here, you can see that the bladder neck and the proximal urethra in this person are going to get 75, even 80 gray, and you can see why people have problems in terms of radiation proctitis as well. So what is the existing OAB data that we have for the male radiated patient? And some of this is taken from a lot of these longer longitudinal studies, for example, CAPTURE, where really the radiated patients, and this is single modality, our primary treatment type, are kind of in the middle of the pack. And radical prostatectomy seems to have the most problem, but brachytherapy, in terms of incontinence, and brachytherapy is responsible for more bother over time. And similarly, in this study, there really almost appears to be very little long-term urinary symptomatology. But it's not represented here, but a lot of these patients, though, do have bowel function decline and bother. Let's look at some of the historical characterization of avoiding dysfunction in radical prostatectomy patients, and this is a historical paper from NITI looking at the ISD and bladder dysfunction that you see in post-radical prostatectomy patients. Looking at a more contemporary paper from Memorial with over 2,600 patients, this demonstrated, however, that roughly 26% of patients have de novo storage voiding symptoms 24 months after surgery. And you can see this also characterized as urgency and frequency. What about the cumulative effect of prostatectomy and radiation? This is another paper looking at patients who had radical prostatectomy alone versus radical plus radiation. When you looked at their symptomatology, the patients that had combined therapy have overall significantly more overactive bladder symptoms than their radical prostatectomy only group. And we always have to make sure that when we're treating these people with overactive bladder, that it's not because there's a problem with the outlet. You know, is it unstable? Is it really a bladder neck contracture? Or are there also calcifications? Okay, so what directions, back to the guidelines, what directions are we going to get from, what did I, when I was part of that, say from the IPT guidelines? So we direct you then to go to the adult overactive bladder guidelines. But of course, this isn't specific for the group that we're talking about, and the ones that I see are almost exclusively radical prostatectomy and radiated patients. I mean, I do see some radiation only, but mostly it's the patients who are salvage prostatectomy. Okay, so this is your classic guideline, but you know, what information or data do we have in the literature for using all modalities, all the way from, you know, conservative therapies all the way to what would be described as third-line therapies in the overactive bladder algorithm. Pelvic floor muscle exercises, and you know, we're all familiar with the utilization of these, for example, pre and post prostatectomy. However, there's very little data when you talk about people who have been radiated. And in this particular study, the bottom line is that there was no difference when you looked at 3 years. But of course, there was just an early intervention. It was like the intervention group had a pelvic floor physical therapy session at 1 month and 3 months. And you can imagine that unless the patient is continuing with the exercises, that you're not going to see any prolonged benefit when you go to 3 years. Pharmacologic management. The most studied agents, as I have listed here, in this radiated group is trospium, sulfenicin, and mirabegron. And in this particular study, this was a group randomized, radiated group randomized to tamsulosin and mirabegron. And the patients in the mirabegron with the added mirabegron had an improved overactive bladder symptom score and improved urinary frequency. What about Botox? This is really the only reference to Botox specifically in the radiated patients. This is from Mike Chancellor, and you do see a demonstration of improved bladder capacity as well as reduced voiding frequency for patients that have been radiated who get BCG, who get Botox in the radiated and BCG cystitis groups. PTNS. We don't use this in our practice at all just because it ends up not being a practical thing when we have patients who are coming from so far away. However, when you look at male patients, there's really no series focused on male patients. There are some males embedded in larger series, but they're not specifically the group that we're looking for, neurogenic or idiopathic. And oftentimes, the radiated patients are excluded from these studies. Sacral nerve modulation. There's also very little data, almost none, in the radiated patient population. We do have some in the colorectal patients, and we're actually doing a trial with our colorectal partners for, they're using it for fecal incontinence, and we are for patients that also have non-obstructive urinary retention simultaneously. So those would have a single implant and be treated for both diagnoses. What about hyperbaric oxygen? We talked a little bit about that yesterday. So this is not for radiation. This study does not look at patients who had radiation cystitis. It's looking at those who did have a history of pelvic radiation, but have symptoms, have a bladder capacity of at least 150 cc's, and are not actively bleeding. So it's before the point where we usually utilize hyperbaric oxygen. And this is at their first visit, just looking at them to demonstrate that the groups were similar in terms of the ones that got hyperbaric oxygen and the ones that did not. And after a full course, which is 80 to 90 minute sessions and 30 to 40 treatments, they did demonstrate improvement in urinary bother and incontinence. So maybe there's a potential for intervening with hyperbaric oxygen when people just start having symptoms rather than waiting until they're bleeding. But then it also comes into what is the cost? Will their insurance pay for it? Per session, if you pay cash, it's $200 to $600 per session, depending on where you are. So let's look at a specific patient. I find that this is the best way, especially when you don't have a lot of data and you are trying to figure out what characteristics might lead you to pick one thing or the other. Okay, so this is a 67-year-old patient, IMRT, 64 gray, 39 fractions, and then had in 2009, and then has a biochemical recurrence, of course. And then he presents to MD Anderson with a PSA of 9, his MRI biopsy, and this is all his AUA symptom score. And so he undergoes a salvage robotic prostatectomy. That is his pathology. He had a lot of hematuria and bladder spasms, in his early postoperative phase. He also had ended up really with a kind of a prolonged catheterization, but this is his first cystogram, so of course this is not getting removed. The catheter is going to stay in. And then at the next cystogram that was a month later, there was still a small volume leak, but the catheter was removed at that time. And then he returned home, which is in Phoenix, Arizona, and the catheter was replaced locally for retention. So we have him back later, and I can't remember whether, I think I may have been the one who scoped him at this time. He has his outlet is wide open, some necrotic debris at the bladder neck. This is kind of a more bird's eye view of the bladder neck in the distance. So we're comfortable that he wasn't obstructed at that point. But his main complaint at that point was, I want my erectile dysfunction fixed. So we sent him to our ED specialist, who's a colleague of Mo's. And so he gets a IPP and a mini jupette. Now, I didn't characterize his incontinence at this point. It's probably about 5 or 6 pads a day. So here's just a representation of a mini jupette, and we can maybe talk about that for those who are left to discuss questions. But the procedure itself was uncomplicated, but he didn't actually have any improvement in terms of his incontinence. So he gets referred to me for management of his incontinence. So at this point, 8 to 10 pads per day and alternating with a condom catheter. So really basically profuse incontinence. So I look at him, of course, in the stadium of radiation. He's had prolonged catheterization, retention. Of course, I'm going to redo his cystoscopy, and this is the appearance at this point, kind of a fixed bladder neck, a lot of radiation cystitis, very pale appearing, just proximal to the anastomosis. So at this point, this would be definitely someone who I'm going to do urodynamics in. So he has both detrusor overactivity and intrinsic sphincter deficiency, but again, he's very decompensated. So that gives you the question about whether some of this is related to the decompensation. He has high amplitude, uninhibited contractions, not a lot of leakage associated with it, but some. His baseline pressures do return in between contractions. This is the Valsalva leak point pressure, which is low. And once you subtract the amount that he leaks, the maximum capacity that we get on him is 150 cc's. So, time to decide what to do at that point. And I decided to proceed with treating his ISD. So he got an artificial urinary sphincter, standard placement, standard activation. And of course, after activation, he has urgency and urgent continence. We start with oxybutynin, followed by mirabegron. So He calls 10 days after starting the mirabegron and saying, this is not working. Of course, this is an inappropriate, length of treatment for mirabegron. But he, flies in from Arizona and says, please look at this for me. So I was like, okay, it's not because of your artificial urinary sphincter cuff. The cuff is closed. I really, don't think I could get this any tighter if I tried. So that's not the problem. We redo his urodynamics, and really even worse in terms of the amplitude of his detrusor contractions. He has even more leakage. So we begin the third line therapy discussion. And we do now clinic PNEs, and we have fluoro. How many people do clinic PNEs in their clinic? And do you have fluoro? Some, okay. So he had a great response, 80% reduction, so qualified to go ahead, with an implant. So what I normally do is, if they have a successful PNE, then I don't then do another first stage, just, do a single stage implant. So first 2 months, fantastic, loves the device. Then he starts having, issues going to different programs. Then we check a film to make sure there's no problem with the lead placement. It's in, standard position. Then I'm saying, okay, he had such a great response. Why don't I consider, checking out the other side? So then we take him back to the OR. So I remove the right side and place a left side device. Yes, I didn't have a bilateral placement. I removed the one side and just left the contralateral side in. So this works great for 6 months. Then there's a rapid decline. So we remove the SNS, and then move on to our other alternative, Botox. So he has a 70% reduction in his leakage with 200 units. And then we, wait, for an interval, and then subsequently I use 300. So at that point, which is still now, he's very happy. So, in this situation, the sacral nerve modulation, just, I don't know if it's because of the progression of changes, but it worked, and then it didn't on both sides. But then the Botox at this point is working. Will that work indefinitely? I don't know. So this is my current algorithm, and which is kind of very tiny, but what it really gets down to is, based on the patients that I have had, deciding based on some of the urodynamic criteria in terms of whether the amplitude of their contractions, in terms of their overactivity, and whether they're leaking, which one has worked in terms of sacral neuromodulation or Botox in the patient. For me, patients with higher detrusor contractions in terms of overactivity have responded better to Botox rather than sacral neuromodulation in this patient population. Whether that will hold, I think this is something that is going to obviously have to be validated by more patients to determine if that's correct. And of course, if none of those work, then you're down to past third line, and you're looking at augmentation or even potentially diversion. So one of the issues that we have is the data in this population is minimal, and I think people are treating patients kind of anecdotally, and as I am trying to figure out what works, because all the data is in the female patient population. The effectiveness of these third line therapies in these patients are completely unpredictable in some degree. And I think that the symptom control is difficult because their bladders and their symptoms are changing, month by month. And for me, I've been trying to use urodynamics to stratify the therapy for these patients.